persons and their colleagues. Now today we are actually starting with the basic science session, which involves basic research and knowledge to actually practice as a clinician. I am talking about the robotics, starting from the initial times of surgical robo, which was started in 2000 in US. We have two hospitals where we do robotic surgery. You can see here, initially it was approved in 2000, but the robotic surgery expanded rapidly in last 10-15 years. I was actually trained in Hinderford Health System in Detroit in 2004, and that was the time when it was in primitive stage. They were also learning Hinderford Health System, Dr. Manimenan and his team. We used to take hours together for simple things, what was for every younger surgeon also does in 1.5 hours. And those days it was taking 6 hours, 8 hours and 9 hours. There were 3 to 4 robots, and all robots were actually doing single case in a whole day. That was the situation of robotics at that time. It was developed to overcome the limitation of standard laparoscopy. We all know laparoscopy is widespread. It is done by most of the surgeons, general surgeons, gynecologists, urologists, and so on. Now, robotic assisted surgery uses smaller incisions and insufflation of the abdominal space, as we know. It is actually a refinement of the laparoscopy. The robotic camera and instruments are placed through the ports of the body like a laparoscopy, but the port size and instrument size, diameter are different. The surgeon is not at the same console, is not at the patient, is not touching the patient, is elsewhere, and he need not be in the same hospital, he need not be in the same city, he need not be in the same country also. We can as well operate from here on a patient in US or UK. And the robo assistance is essential, and internet connection is absolutely predicament for the tele-robotic surgery. The components of system in basic robo, we all know the console where surgeon sits and binocular lenses are placed in the 3-dimensional image. In fact, it magnifies to 16 times, and a motion filtration system is there. Most surgeons initially have some tremor, and that is scaled down to minimal. Over a period of time, that tremor also disappears by the surgeon. Robo has a mobile tower, which is as tall as a human being, with 4 arms, 1 for a camera and 3 for instrument ports. The bedside cart is there, the camera and light source, and which transmits images to the console. This is a console where we operate in the KIMS hospital, Secunderabad. It's a SI machine. The first machine what I have seen is S machine in USA, in Henry Ford Health System. Now at that time, it had only 2 arms. They were trying to add the 3rd arm at that time. You can see all the 3 components here. The surgeon console. Luckily, the surgeon is nearby. This is a patient card. This is a vision card. And we all actually learned on the systems. The outside there are some operating systems where we can actually learn at least 8 hours of training period essential before you can actually touch a patient. That's a rule at that time. In nowadays, see, many hospitals have robots in India also. In 2004, there was no robo in India. This is a surgical robo what I have seen in 2004. It had only 2 arms. This black one on the other side, and the camera was just behind the stem. This robo also was good, maybe because 2 arms were there, the time was a little longer, but it actually combines the benefits of laparoscopic surgery with 3-dimensional magnified imaging. Now the advantages we all know, they have smaller incisions, less blood loss, actually you can get into the deeper areas more easily, and short hospital stay, and improved cosmesis also, and lower incidence of surgical complications. Most of these benefits, as we see, are rosy, but actually long-term survival and patient survival benefit for a patient is not actually proved. And if you see, this is a team, Dr. Manimenan, Peabody, in 2004. They have trained hundreds of robotic surgeons in last few years, last 20 years. The most common surgery done by robotic assisted surgery is prostatectomy, because their screening system is very good. They catch the patient very early. The surveillance system also very strong, and patients also are more educated. So, chance of seeing a patient with advanced prostate cancer in US is quite rare. More than 85% of prostatectomies are now robot assisted in USA, and it has many advantages like less blood loss, fewer transfusions. The transfusion is very rare. Actually, most often it is only reserved, but blood is not kept in the operating theatre for standby. The patient actually is discharged in 2 or 3 days. In general, the robotic assisted surgery also has same risks, but some of the risks are little lessened, like infection, bleeding, risk of anesthesia. As surgeon improves, the anesthesia time also decreases, thereby decreasing the morbidity for patient. Sometimes there could be mechanical failure because of multiple components. The standby time of a standard robo is 8 to 9 hours. Initially there were some legal complications for the robotic surgery patients. Then in the court, the surgeons were saying that there is mechanical failure. It can't be attributed to the robo. Any complaint occurs, it is due to surgery and surgeon and not because of the component, because all components should be checked properly before you actually undertake a surgery. That's a rule. The take-home points in this is a rapidly expanding technology in multiple surgical specialties. It is not just urology, because it may not survive the urology turnover in a single hospital. So gynecologists, general surgeons, and even the radiotherapists are using a robo actually to decrease the wastage of the radiation and to pinpoint the focus. Although robotic assisted surgery has some short-term benefits including direct perioperative period, it is equivalent to long-term outcomes in compared to open surgery. In fact, there is no study which has shown that robot has done better than open surgery in terms of long-term survival and specific cancer-free survival rates. Robot surgery is safe, overall complications are very less, but adding robot to the surgical equation insert another entry for a point of error which has to be taken care of. So the maintenance is absolutely essential, because it's not just like a laparoscopy where you can enter and suddenly you can come out and do open surgery. Every robotic surgery is recorded, every complaint is also recorded by the whichever system and has to be analyzed post surgery. The take-home points are ultimately the direct manifestation. Every surgery is dependent only on surgeon. All other things are like the bonded labor for him. The robo has no intelligence, it has zero IQ, so you can't expect it to do anything when you are not doing well. When your instructions are faulty, robot is down to cause complication. Now it's not the technology. The potential areas for improvement are reduction error of robotic surgery, more standardized training. We all know the models have changed. S to SI to XI. Now we have the single port robotic system, which is more expensive but still is coming to work in more hospitals. Now this is about the take-home points. I'll go to my presentation. This is the basics of robotic surgery. I'm going to show some of the surgical exercises where we have done, and then found that not only for basic conditions, surgical conditions, we have already done for some of the complicated cases where robot is essential. It has proved its advantage over the standard laparoscopy or open surgery.
Yeah, you are into second talk now, Dr. Kammela sir?
Yes.
Yeah, thanks for your open remarks, and we'll request you to continue the basics in robotics in urology. Sreedhar.
Yeah. Now, first case I am going to show is robotic partial nephrectomy, where we have seen a young lady, absolutely healthy, didn't have much of complications. On a muscle checkup, there was found to be a little bit of bump on the left kidney. She had no symptoms like loss of appetite or loss of weight. Because of obesity, mild obesity, there was diabetes. Ultrasound showed a 3 cm left renal SOL in the mid pole. There was not much enhancement with the contrast medium. You can see here on this left kidney there is a small hump here. That's all. Nothing more than that. It's merging with the parenchyma of the kidney. You can see with contrast enhancement, little bit of contrast there, but otherwise it is not separate from the kidney. Now we have seen that this is a tumor can be excised by a partial nephrectomy. You can see most of the kidney parenchyma, because fortunately it is on the exterior and could be inoculated easily. There was no distortion of the ventricular system. It is actually in the mid pole of the left kidney. Now this is the hilar dissection, where we have actually identified the artery, and then you can see the broader one is the vein. This is the vein, this is the artery. After clamping, we have actually cut the tumor. You can see here, this is the excised area. We mark the tumor about 1 cm all around the tumor, and then we have cut the excised tumor. We are closing it with the suture, continuous suture, and then we didn't expose the pelvic calcium system, so there is no chance of any leak. It was a clean surgery, no mishaps, no bleeding, absolutely safe, and it took hardly 45 minutes for the robotic excision of the small partial nephrectomy. Now, smooth, the second day, drain was removed. There was nothing much in the drain. On the third day, we have discharged. It showed a clear cell carcinoma. It's about 1.5 years now. She is doing well. Now another patient, 35-year-old man, presented with vomiting and facial edema of 10 days duration. He was a healthy man before that. And ultrasound showed mild bilateral hydronephrosis and CT scan showed fibrosis which are increasing at the level of 3 to 5. This is a standard retroperitoneal fibrosis where you can see the physical system is little dilated, the ureter was drawn little more medially, and then this area was doubtful. We suspected a retroperitoneal fibrosis because of the rising creatinine. We have put in double J stents. Stents have gone easily. Both have been kept easily. And after about 10 days, the creatinine came back to 1.6. We thought of excising the robotic plaque. Now we have taken the patient onto right lateral liquidus position, excised the plaques, and then we have shifted the patient position to left side, lateral liquidus, and then excised the retroperitoneal fibrosis. You can see here the fibrosis is actually encasing the ureter from about almost L3 level to L5. I think actually the tough layer of fibrotic area, we have cut over that. Some places were little fibrotic, it looked like a bone-like thing because of severe calcification. Ureters were much deeper inside, and once we have done that, we have actually shifted the patient position to other side. You can see this is the ureter in the center. What we are removing is a tough fibrotic areas which are actually encasing the ureter to a great extent. Now we can see another video here. This is the fibrotic area where it's cutting through our knife. It's cutting through our knife. It's actually so fibrotic that it was difficult to cut. We thought of just opening it and leaving it, but for fear of severe recurrent fibrosis, we can see this is the area where there is a dense fibrosis. It was not looking like fibrotic, it's a calcific area. Now, these calcific areas, when we removed that, it had actually calcium deposits as well as plaques of retroperitoneal fibrosis. And this patient recovered in 3 days. We discharged him and we removed the stents. It's about 2 years since that time. The third case is a Mullerian duct cyst. A 22-year-old young man presented with lack of secondary sexual characters. His main symptom was that the mustache and beard are not there. The father was saying that whether he is a female, whether he is going to become an adult male or not. He was taking testosterone injections at his place at a small town, and he had small suprapubic discomfort which was not very severe, so they didn't bother. He didn't have other sexual features for a 22-year-old male. There was no facial hair and penile size was average. Right inguinal testis was there, left testis was normal, and seminal cells showed classically azoospermia. So we are dealing with a patient of hypogonadism with unexcellent testis, azoospermia, and whether he had really normal male chromosomal typing. We have checked and it's normal XY. And ultrasound showed surprisingly a 15 into 12 into 10 centimeter cystic lesion in the pelvis, which is a pyriform shaped thing. He is a boy, no hair on the chest, and truncal obesity. We have done the organolepexy on the right side because it was inguinal testis. We brought it down to the scrotum, and later the CT scan showed that there is a big area. You can see this is this one. This is bladder. This is the area, cystic area, which is looking like a pyriform shape, and then some liquid inside. So this was huge behind the bladder and in front of the rectum. So we wanted to remove that. We wanted to see what it was. We thought it was a Mullerian duct cyst because there was hypogonadism. It was not actually, the shape was looking like a uterus, but he had both testes. So probably it is failure of the Mullerian duct system that has led to a cyst and the port placement. As soon as we entered the abdomen, this is a large cystic area. We poked into it, it was getting some cloudy fluid from inside. So we assured that the cystic area